enter into the liver via portal circulation before reaching to the final systemic circulations. Here, the different factors affecting the absorption. First, when we administer the drug through the oral route, the propal breakdown of the tablets or drug molecules through the disintegration and dissolutions of the drug through the different media is important. Then proper absorption is possible. The formulations also play a critical role. When more binder is present in the formulations, so it is very difficult to disintegrate in the stomach and absorption is decreased. Lipid solubility, more soluble, more permeable, the pH and ionization, presence of other drugs by transporter inhibition mechanisms, gastrointestinal motility, more motility, the food particles are move faster through the peristaltic movement. Then food decrease the absorption of the toxicants. Certain disease conditions of the vital organs such as the liver, kidney, brain, and heart also impair the absorption mechanism. Vascularity is directly proportional to the blood flow to that specific organs. Metabolism to the livers. It creates the polar compounds and excreted from the body. If it is impaired, then there is a change in the absorption. More surface area, more chances of absorption, lesser particle size, increase the absorption as compared to the bigger particle size. With this, we switch over to the distribution. After drug is absorbed systematically from the site of administration, drug molecules are distributed throughout the body by the systemic circulation. The rate of distribution to the organ or tissue is determined primarily by the blood flow and the rate of distribution out of the capillary bed into the cells. Location and extent and distribution are depend on the drug physiochemical property. The final distribution depends largely on the affinity of the xenobiotic for the various tissue. The penetration of toxicants into the cells occur by the passive diffusion, or sometimes there is a special transport process. Small water-soluble molecules and air apparently diffuse through the aqueous channel or in the cell membrane. The lipid-soluble molecules rapidly permeate the membrane itself. Very polar molecules and ions of even moderate size cannot enter the cells easily except by the special transport mechanism. Drug distributed in two-stage process, delivery of the drug to the tissue by bloods and diffusion or uptake of the drug from blood to the tissue. The drug have a different affinity towards the different organ or the tissue. So drug affinity and blood flow for the tissue of organ refer to the partition and accumulation of drug in different tissue. A drug distributed in this graph, there is a 5 group of tissue at various rate of equilibrium. Here you can see there's an adrenal gland, kidney, skin, muscles, and fat. And here's the availability in microgram per ml, and this is the time. So that the distribution of the drug is different in these 5 tissue. Blood flow, tissue size, and tissue storage time factor affecting the drug distributions. Here we can see there is a blood flow of the different organ is different. In the table, we can see the lungs, kidney, livers, and up to fat, there is a blood flow difference is there. Fat having the low blood flow and lung having the more blood flow rate. Based on the blood flow, there is a perfusion rate is also difference. So in general, the initial phase of distribution is dominated by the blood flow, whereas eventually the distribution is determined largely by the affinity of the tissue. The toxicants are divided mainly into two forms, the free form and bound form. Free form is pharmacologically active, can cross the cell membrane, and bound form, which bind with the plasma protein, and it is pharmacologically inactive. Here in this graph, we can see this is the free form available within the body, and these large portions are having the bound form of the drugs, which act as a inactive, pharmacologically inactive forms. So drug binding to the plasma protein may prolong the drug action and reservoir of non-metabolized drug in the body. Suppose take an example of trypanosomiasis. The Sumin drug is administered through intravenous injections and it is effective for the 3 months. And the warfarin, there is a 97% bound to the plasma protein and 3% is remain as the free drug. So the access duration is increased by bounding of the toxicant. However, the interaction of chemical with the plasma protein is reversible. The bound form and free form is available in the plasma as well as interstitial from bound free and tissue or the body water. It is converted interchangeably from one region to the another part. So when there is availability of the toxicant is required, it is released from the bound form to unbound form. The plasma protein binding half-life of clofibril acids in the mouse, rat, and man. The human have a 97% plasma protein binding, rat have a 75, and mouse is 45. The plasma protein binding can also give rise to species difference, which shows in this table. So clofibril is primarily eliminated in all three species by the renal glomerular filtration without tubular reabsorption. And there is a species difference in drug half-life also. This improves the absorption, it increases the bioavailability. The plasma concentrations constitute a window for obtaining the information on distribution of the bulk of the drug in the body, how it change over the times. For better understanding, here is the comparison of effect of 5% displacement of drugs from binding of two hypothetical drugs, drug A and drug B. Here, before displacement, the parent percent drug bound is 95 and percent free drug is 5%. In another example of drug B, the percent drug is 50% and free drug is before 50%. So after displacement, 5% displacement, it becomes 90 and here free drug is 10. Similarly, in group B, it becomes 45 and here 50%. But when we check the percent increase in the free drug, here it becomes 100% free drug availability as compared to the before displacement conditions. And here only 10% free drug available. Why it is important? Because of that free drug is pharmacologically active and it produces sometimes more toxicity after smaller displacement of the drug from bound to free forms. Another term that is bioavailability. The percentage of an administered dose of a drug that reaches to the systemic circulations and hence produce the desired biological effect. The bioavailability is considered to be 100% for the IV injections. And rest of the route of administration having less than 100% of the bioavailability. Here in this graph, when we administer the drug through intravenous, In the initial phase, it reaches the 100% availability, and by the course of time, it reduces to lower sides. Whereas in the oral administrations, in initial phase, it is 0. Then by course of the time, it is increased, and slowly it becomes down. So bioavailability is calculated by AUC of oral divided by AUC injected multiplied by 100. The volume of distribution. Volume of distribution is also termed as a VD, is a hypothetical volume of fluid into which drug is distributed. There is a 3 functional distinct water compartment in the body. First is plasma, interstitial fluid, and last is intracellular fluids. This plasma is about 4 liter, interstitial fluids and extracellular fluids. In body, total body water consists 60% of body weight. Suppose take an example of 70 kg human beings having the 42 liters of water content, which are mainly comprised of intracellular fluid and extracellular fluid. Intracellular fluid is 40% of body weight. It becomes 28 liters. Whereas the extracellular fluid becomes 20% of the body weight. It's approximately 14 liters. Within the extracellular fluids, there's the plasma and interstitial volume. The plasma is approximately 6% of the body weight. It roughly 4 liters. And interstitial volumes is 14% of the body weight. It near about 10 to 11 liters for the 70 kg human beings. So there's these 3 compartments. Suppose take an example of plasma compartment. Drug have a large molecular weight or bind extensively to the plasma protein. Whereas the toxicant or the drug available in the extracellular compartment have a low molecular weight, hydrophilic, distributed in plasma and interstitial fluid. Whereas in intracellular compartment, the drug has low molecular weight, hydrophobic or lipophilic in nature, distributed in 3 compartments, and may be accumulated into fat, or it can pass the blood-brain barrier. The example is ethanol. Here is the example of factor that contribute the volume of distributions. Here we can see chloroquine have a 100% volume of distributions as compared to warfarin, that is 0.1%. So warfarin is highly plasma protein binding with distribution into the tissue, whereas the chloroquine is a high tissue uptake and trapping into the lysosomes. The factor affecting the distribution of toxicant, which include lipid solubility, molecular size, degree of ionization, cellular binding, duration of actions, therapeutic effect, toxic effect. When the certain factor related to the body, there's vascularity, transport mechanism, blood barrier, placental barrier. That is, blood barrier includes the brain-blood barrier, the placental barrier, plasma binding protein, free and bound form of the drugs, drug interactions, disease state, drug reservoir, and volume of distributions. In pregnancy, drug crosses the placenta and may affect the developing fetus. Drug can also secrete through the milk, via mammalian glands into the saliva. But one characteristic is important: the drug should be highly lipophilic when it is excreted through the milk, saliva, or any other special route, specifically through the sperm also. Storage of toxicant in the tissue. Some xenobiotics attain their highest concentration at the site of toxic action, such as carbon monoxide, which have very high affinity for the hemoglobin, and paraquat, which accumulated in the lungs. Other chemical concentration at site other than the target organs. Sometimes it may possible. Suppose take an example of lead is stored in the bone, but manifestation of lead poisoning appear in the soft tissue. The compartment where a toxicant is concentrated but is not a major site of toxicity for that chemical is described as a storage depot. The biological half-life of stored compound can be very long. Toxicants in this depot are always in equilibrium with the free fraction in the plasma. Plasma protein binding as a storage depot. Binding of the chemical to the plasma protein is a major storage depot. And several different plasma protein bind xenobiotic and some endogenous constitution of the body. Many drugs bind reversibility to the plasma protein, especially the albumin. Here, drug combined with the albumin and it makes the drug albumin complex, then it becomes inactive. And rest of the free drug is available. Only free drug can distribute it and bind to the receptor, metabolize and excrete it. Here in this way, compartment 1, this is a drug molecule, this is protein, and this is a drug protein complex. And this is a barrier, so only free drug can pass from one compartment to the another compartment and it's produced the pharmacological or toxicological effect. The bound fraction is determined as the difference between total and unbound fractions. A compound with high degree of plasma protein binding may not show toxicity when compared to one that is less extensive bind to the plasma protein. Albumin is the major plasma protein and it binds many different drugs and xenobiotics. Albumin is present in the plasma at concentration of 500 to 600 micromolar, is the most abundant protein in the plasma and serve as a depot and multivalent transport protein for many endogenous and exogenous compounds. Another alpha-1 acid glycoprotein, although present at much lower concentration than the albumin, but is also play an important role in plasma and compound with basic characteristics tend to bind it, whereas albumin have a acidic characteristics tend to bind it. Transferrin, beta globulin is important for the transport of iron in the body. Other major metal binding protein in the plasma is cellulose plasmin, which carries the copper. The alpha and beta lipoprotein are very important in the transport of lipid soluble compounds such as vitamin, cholesterol, and steroid hormone. Plasma gamma globulin are the antibodies that function specifically in immunological reactions. The extent of plasma protein binding varies considerably among the xenobiotics, such as antipyrin are not bound. Others such as a secobarbital are bound about 50%, and such warfarin are bound at 99%. So in one clinical trial, comparing the efficacy of tetracycline with that of penicillin sulfonamide complex mixture in the management of the bacterial infection in the premature infant. The penicillin sulfonamide mixtures led to much higher mortality than did the tetracycline because the sulfonamide displaced the considerable amount of the bilirubin from the albumin. That free bilirubin then diffuse into the brain of the newborn baby, crosses the blood-brain barrier and causing the severe form of brain damage termed as kernicterus. Liver and kidney act as a storage depot. These two organs probably concentrated more toxicant than do all other organs combined. Chemicals that have a long half-life, such as PFOA, preferably deposited into the liver due to the high affinity of liver-enriched OATP transporter that preferentially transport certain perfluoride chemicals into the liver deposited. Another example is alpha-2 mu globulin proteins which are more in the male rat, which bind a diverse array of the xenobiotic, include metabolite of D-limonene as a major constituent of the orange juice and 2,4,4-trimethylpyrin found in unleaded gasolines. The chemical alpha-2-mu-globulin complex is taken up by the kidney, where it accumulates within the lysosomal compartment and damage the proximal tubule and cause the nephrotoxicity. Another example is chloroquine has a very high volume of distributions, which is determined largely by the extensive storage in the peripheral tissue. The physiological pH, chloroquine is non-ionized, but once it enters into the cell, it takes up into the acidic milieu of the lysosome, where it becomes highly ionized and subsequently trapped into this compartment of the lysosome. A variety of xenobiotic cells is attributed, and it leads to the phospholipidosis. Here is this mechanism. Here's external side 7.4 pH. When it enters into the cytoplasm, having the 7.4, but when it enters into the lysosomes, then the pH of that medium is 4.5. So the chloroquine is trapped into the lysosome, and it leads to phospholipidosis condition. Fat as a storage depot. There are many organic compounds that are highly stable and lipophilic, leading to their accumulations in the environment. Highly lipophilic toxicants are concentrated in the body fat, where they retain for the longer duration. Potential toxicological significance for that storage for the different compounds such as a pesticide, aldestine, chloroquine, DDT, and this many more are stored in the fat for the longer durations. Toxicants appear to accumulate in the fat by dissolutions in the neutral fat, which constitute about 50% and 20% of the body weight of the obese individual and the lean athletic individuals. So, in sometimes, several studies have shown that sign of intoxications can be produced by the short-term starvation of the experimental animal that were previously exposed to the persistent organochlorine insecticides. It means when there is a reduction in the fat in the body, that drug is released and produce the toxicity. That mostly the toxicants with high lipid water partition coefficient may be stored in the body fat, and higher amount are likely to be retained in the obese individual. And if the toxicants accumulate at the site other than the target organ for the longer durations, it acts as a depot. Bone as a steroid depot. Compounds such as fluoride, lead, strontium may be incorporated and stored in the bone matrix. For example, 90% of the lead in the body is eventually found in the skeleton. In increased osteolytic activity, after the parathyroid hormone administrations, lead to enhanced mobilize from that bone part to the systemic circulation. Ultimately, deposition and storage of toxicants in the bone may or may not be detrimental. Lead is non-toxic to the bone, but chronic effect of fluoride depositions, skeletal fluorosis, radioactive strontium, osteosarcoma, and other neoplasm are well documented in this depot. Blood-brain barrier. Access the brain is restricted by the presence of two barriers. First is blood-brain barrier, and another is blood-cerebrospinal fluid barrier. This is a schematic diagram of the blood-brain barrier with the different transporter available in the capillary endothelium and this is the nothing but the glial cells, specifically astrocytes, which play a tight junctions of interepithelial cell layer of the brain. And this is a blood cerebrospinal fluid. This is a choroid plexus epithelium, and this is a different transporter available. On this side, there is a cerebrospinal fluids, and here is a blood, and this is a brain capillary and brain. So many toxicants do not enter into the brain with appreciable quantity because of this barrier only. Diffusion is more lipophilic compound through the endothelial cell membrane is encountered by xenobiotic efflux. The efflux transporter include MDR1, BCRP, MRP1, MRP2, MRP4, MRP5 is located in the different apical plasma membrane, and it helps into the xenobiotic transfer. Numerous ATP-dependent transporters have been identified as a part of blood-brain barrier and comprised of members of ABC and SLC family. One seminal study demonstrated that MDR1 null mice were far more sensitive to the insecticide, ivermectin, and the anti-cancer agent vinblastine. The brain uptake of this compound was increased 26 to 80-fold respectively, and the sensitivity of neurotoxicity or lethality was increased up to 100-fold with this MDR1 transporter mechanism. The blood flow through the choroid plexus is about 10 times higher than in the brain. The feature that provides the high turnover of the biological fluid necessary to support the dynamic change in the nutrient required for the neuronal functions. Furthermore, the protein concentration in the CSF is much lower than that of the other body fluid. In addition, morphine is 3 to 10 times more toxic to the newborn than the adult rat because higher permeability of the brain of the newborn to morphine. Blood-brain barrier of the newborn baby is not fully developed. Similarly, lead produces encephalomyopathy in the newborn rat but not in the adult. It happens because of stage of development of blood-brain barrier. Toxicant across the placenta. The placental barrier has been associated with the concept that main function of the placenta is to protect the fetus and passes the subnutrition from mother to the fetus. However, the placenta have a multifunctional organ which provide the nutrition and exchange of the maternal and fetal blood gases, disposal of fetal excreted material, and maintain the pregnancy throughout the complex hormone regulation. So anatomically, the placental barrier consists of the several cell layers. It is approximately 6 layers available in the placenta. So like nutrient, toxic chemical can also transport through the placental barrier and it produces the toxicity. And there is a different terminology of the placenta, the endothelial, and there is a species differences there in the anatomical structural characteristic of the placenta. Okay. So here we are discussing about the placental barrier, which is relatively permeable to the toxicity. And certain toxicants, it acts as a tetrodotoxin, which causes the birth defect, suppose of thalidomide, retinoids, ethanol, and diethylstilbestones. The certain transporter is already available on the cytotrophoblast, which is act as a progenitor of syncytotrophoblast. This is the most of the transporter is Most of the transporter is available in the syncytiotropoblast and few are available on the cytotropoblast, which are important for the distributions of the drugs. Redistribution of toxicants. The most critical factor that affect the distribution of xenobiotic are the organ blood flow and its affinity for the different xenobiotic. The process where the toxicant move from one area to the another area. When drug is remain in the binding form at depot or some area, after some time it is redistributed to the another area and it produces the toxicity. For example, 50% of the dose of lead is found in liver 2 hours after administration. But 1 month later, 90% of the lead remain in the body is associated with the crystallized lattice form of the bone. Similarly, persistent organic pollutant do not distribute it rapidly to the fat, but accumulate selectively in the adipose tissue over a period of time. But when there is a starvation or muscle wasting, that deposition toxicant is removed from that part and produce its toxic effect. Then last segment, that is excretion. Toxicants are eliminated from the body by the several routes, in which kidney perhaps the most important organ for the excretion of xenobiotic occurs. The biliary excretion of xenobiotic and or their metabolite is most often as a major source through the fecal excretion, but number of the other source can be significantly for the some compound. Toxicant with a high lipid or water partition coefficient are reabsorbed efficiently, whereas the polar compound and iron are excreted in the urine. The functional unit here in this graph, this is a kidney, this is a cortex part, and this is a medulla. The blood provided to the afferent and efferent, this is a ureters. Where in this schematic diagram, we can see the functional unit of the kidney, that is called nephron, which comprise of glomeruli and capillary tuft network, which play an important role for the filtrations of the blood. And depending on the physiochemical property of the compound, it may reabsorb from the tubules and back into the blood system. The glomerular filtration rate vary considerably across. The varies from one species to the another species, is ranging from high approximately 10 ml per minute per kg in the mice and about 1.8 ml per minute per kg in the humans. This appears to be determined by the relative number of the nephron per kilogram of the body weight. So here the glomeruli capillary have a large pore, approximately 70 nanometer, which filter the compound up to molecular weight is about 60 kilodalton. It's smaller than albumin. So lower molecular weight compound are excreted or filtrated directly through the glomerular filtration rate. I examine treatment of the phenobarbital poisoning with the sodium bicarbonate. In this condition, the percentage of the ionization is increased markedly within the physiological attainable pH range. For weak organic acid, such as phenobarbital, pKa is 7.2. So such that alkalinization of the urine increase the fraction of drug in the ionized state, and thereby urinary excretion of the phenobarbital is increased. So in similar manner, excretion of salicylate can be accelerated by administration of sodium bicarbonate. An anti-neoplastic drug, cisplatin, is a substrate and inhibitor of OCT2, a dose-limiting nephrotoxicity associated with this drug may be directly related to the uptake medium concentration of the drug in the proximal tubule epithelium. PPT2 knockout mice urinary excretion of antibiotic cefadroxil was markedly increased due to the almost complete lack of reabsorption from the urine. And another transporter, MDR1, MRP2, and MRP4 are the efflux transporter, which are localized in the luminal brush border of the proximal renal tubules, where they pump xenobiotic out of the cells into the tubular fluid. They enhance the excretions of the toxicants. In all active transport systems, there is a competition of renal secretion of xenobiotic. This fact was taken advantage during the World War II. When there is World War II, there is a specific requirement of the penicillin drug for the soldiers. So penicillin was in short supply. So penicillin is selectively secreted by the organic acid system OATs transporter of the kidney, and the lengthen its half-life durations of actions. Another acid was sought to compete with the penicillin for the renal secretions. So half-life of penicillin is small, so immediately removed from the body. And stock of penicillin is not available. So they make an idea to give the probenecid to compete with the transporter of OATs, and was successfully introduced for this purpose in World War II. Some xenobiotics are eliminated more slowly in newborn than in the adult, therefore may be more toxic to the newborn. For example, for clearance of the penicillin by premature infant is only about 20% of the observed in the older children. So the dose regimen for the infant or the children is slightly different than the adult when there is any disease or infections in the children population. Another example is cephaloridin, are the nephrotoxic in adult animal but not in newborn. The reduced toxicity results directly from the lack of active uptake of cephaloridin by the kidney in newborn. And excretion through the fecal route. Fecal excretion is the second major pathway of elimination of xenobiotic. Sometimes undigested material, macromolecules, certain polymer are directly excreted through the feces. Here's a schematic model showing the different transporter on the hepatocyte, and this is a biliary excretion route. This is a different influx transporter available in the biliary section. So summary of excretions. There is a different mechanism of excretions for the urine, bile, lungs, saliva, milk, and sweat. Mostly it includes active and passive diffusion, except in the urine it becomes glomerular filtration. And drug excreted with the help of that mechanisms. The rate of excretions is calculated by rate of filtration from the glomeruli plus rate of secretions from the renal tubules minus rate of reabsorptions, which gives the exact rate of excretion. Biliary excretion. The biliary route of elimination is significant source of contribution of fecal excretion. Most of the xenobiotic are metabolized in the liver, and through the bile, it is excreted to the fecal material. In general rule, low molecular weight compounds are poorly excreted into bile, whereas the compound or their conjugate with molecular weight exceeding approximately 325 can be excreted in appreciable quantity. And species variations in the biliary excretion is also compound specific. There's no much species specificity is there in the biliary excretion. And the foreign compound are excreted into bile, often divided into the three classes on the basis of the ratio of their concentration in bile versus that in the plasma. So it is divided in class A, class B, and class C. A ratio of bile versus that in the plasma nearly 1 in class A, which include the substance like sodium, potassium, glucose, mercury, thallium, cesium, cobalt. Similarly, class B having the ratio of bile versus plasma is greater than 1. And class C is below 1. So compound rapidly excreted into the bile are usually class B substance. However, compound does not have a high concentration in the bile for biliary excretion to the quantitative importance. For example, mercury is not concentrated in the bile, yet bile is main route of excretion for the slowly elimination of the substance. The biliary excretion of xerobiotic mediated by MRP2, BCRP, and MDR1 usually result in increased excretion of toxicants out of hepatocytes and into bile. The inhibitions of BSEP by the pharmaceutical agent troglitazole and much greater extent troglitazole sulfate competitively inhibit the BSEP functions and leading to intrahepatic cholestasis, which may contribute to the hepatotoxicity of the troglitazole, and it is withdrawn from the market. But a non-steroidal anti-inflammatory drug cause the intestinal ulceration that can be abolished by bile duct ligation. Another very good example is the dysfunction of the hepatic extraction causing the toxicity in the statin-induced myopathy. Here, the OATP1B1. This transporter is important for the transfer of the statin from muscles to the blood and is reached to the livers. When there is an inhibition of OATP1B1, statin is not transferred and the availability of the statin in muscles and the blood is increased, which is lead to impair the mitochondrial functions and resulting in the rhabdomyolysis of that animal. The plasma clearance and biliary excretion of organic acids such as BSP, ICG, and DBSP has been used as a evaluated marker for the liver functions. Exhalation. Substances that exist predominantly in the gas phase at the body temperature are eliminated mainly by the lungs. When any volatile liquids are in the equilibrium with their gas phase in the alveoli, they may be excreted via the lungs to the exhalation mechanism. It is for highly volatile liquids, certain anesthetic nitrous oxides is also exhaled through the exhalations. The gases with the low solubility in the blood, such as ethylene, are rapidly excreted, whereas the chloroform, which has much higher solubility in the blood, is eliminated very slowly by the lungs. The stress concentration of the high lipid soluble anesthetic gases such as halothane and methoxyfluorine may be present in expired air for as long as 2 to 3 weeks after few hours of anesthesia. So practical applications of this principle of exhalation is seen in the breath analyzer test for determinations of the amount of ethanol in the body, and it is routinely conducted by the police on different occasions. Other route of eliminations include cerebrospinal fluid. All compound can leave the CNS with bulk flow of CSF through the arachnoid villi. In addition, lipid-soluble toxicants also can exist at the site of blood-brain barrier. Milk, the toxic agents are excreted into milk by simple diffusion mechanism. Lipid-soluble xenobiotic diffuse along with the fat from the plasma into the mammary gland and excreted in the milk during the lactation. Certain compounds are accumulated in the fat, such as aldrin, choline, DDT, and so many have been found in the human breast milk. And milk can be a major route of their excretions, and it is affecting the infant. Some transporters are detected in mammalian epithelial tissue. Endogenous compounds such as vitamin B12 are actively transported into the breast milk by BCRP transporter, as well as numerous toxicants including heterocyclic amines and aflatoxin is also transferred to the milk. Sweat and saliva. The excretion of toxic agent in sweat and saliva is quantitatively of minor importance. Substance excreted in saliva enter the mouth, where they are usually swallowed to become available through the gastrointestinal tract absorptions. More important, about 3% or 4% of the milk consists of lipid, and lipid content of cholesterol after parturition is even higher. So it acts as a media for lipid-soluble xenobiotic transport through the milk. Sometimes the toxic compound which are excreted through the sweat may produce a dermatitis because of its irritant nature. So nutshell, here is a summary of drug elimination route: milk, saliva, lung, kidney, urine, feces are important source of eliminations of toxicants. A computational and experimental approach to assess the xenobiotic distributions. In general, empirical determination of xenobiotic absorption, distribution, and elimination experiment involved in the laboratory animal or the study in the human subject are most reliable. However, by certain studies, there is a development of sophisticated analytical method to develop the computational model. It is much more important, in which the absorption, a variety of models are used to estimate the log P value, because the lipid solubility is an important general feature of any toxicant. The concept based on these 4 elements, that is the rule of 5, because determined are based on the multiple 5, that include molecular weight greater than 500, C log P is greater than 5, more than 5 hydrogen bond donor, 10 hydrogen bond receptors. So this is the different parameter through which computational model is developed. Human colon adenocarcinoma cell line and CACO2 is widely used to evaluate xenobiotic permeability, and these cells form a confluent epithelial monolayer with well-defined tight junctions and typically microvilli in apical surface. The CACO2 cells are specifically used to estimate the fraction of xenobiotic that will be absorbed through the gastrointestinal tract. For the hepatobiliary excretion computational model, the later tools, along with the more sophisticated primary hepatocyte culture model, are typically utilized, in which sandwich culture human hepatocytes have become the standard tool to aid the prediction of the biliary excretion and drug-induced liver injury. One such model predicts the poor absorption as a function of calculated log P based on the molecular weight and presence of hydrogen bond donors and acceptors. Last but not least, the classification of the system. The classification of system had evolved to utilize the physiochemical property of the compounds, the solubility, disposition, and the excretions. So in 2005, there is a drug disposition classification system was described, and subsequently in 2015, the extended clearance classification system is called ECCS was described, which are widely used to know the physiochemical property and in vitro and in silico data readily available for the drug discovery based on the molecular weight, ionization, and in vitro permeability, in which it is divided into 4 parts. First, 1A and 1B is highly permeable. It is absorbed. It is for acids, where class 2 is highly permeable for the base. Class 3A is low permeable for acids, and class 3B is low permeable acids with high molecular weight. And class 4 is a low permeable bases, where the absorption is likely incomplete, parasoluble contribution significantly for the low molecular weight, and active uptake of transporter OCT may be involved. So with this, I complete my presentations on absorption, distribution, and excretion of the drugs.